Hemophilia is an inherited bleeding disorder that mainly affects boys, and it is a disease that starts since birth. It is either due to deficiency of factor 8 or factor 9, which are coagulation factors necessary for blood to clot when there is an injury. So although hemophilia is a blood disorder, but the manifestations of hemophilia are mainly musculoskeletal problems. If we prevent the bleeding, we will prevent the complications of the disease. And this what we call prophylaxis. Prophylaxis means regular injection of factor 8 or factor 9 to the boys so that we can guarantee a minimum of factor level in their blood that will prevent the occurrence of the bleeding. And across the world, there are different experiences on many aspects of this prophylaxis. I'm very happy that we have a panel of distinguished experts in this field with variant experience. Some of them practiced this for a very long time, and they have data that they can give to us about their experience over a decade or 2 decades on this practice of prophylaxis.
Prophylaxis means for me 2 aspects. One is to protect the joint of the patient from deterioration. And we know that one severe bleed will destroy the joint, whatever it is. So that is one aspect. The other aspect is if you start early, you may avoid some of the inhibitor problems. So you have maybe less inhibitor development than if you start on demand. This has to do something with our immune system and with the danger signals or the danger situation in a severe bleed. So this is maybe the other important aspect, and this means that you need to treat quite early but with very low dosages. We know that a treatment with a low dosage has less problems in this early age. You cannot cover a whole week if you treat once a week like we do it, but you can see that in these children you have an effect of the one day treatment per week for 2 or 3 or 4 days. And here is a big chance for the half-life extended concentrates for the future. And then if the mother can realize that there are coming bleeds again, you can go to a twice per week treatment, again with a very low dosage. And then we can escalate the treatment depending on the bleeding frequency of the child. And I think this is a quite cheap protocol. And if you look for countries where they are doing this, there are some countries and some centers, and they are quite successful. And I can say we do it now for about 15 years. And in our center we have since 15 years not one inhibitor. And in the center of Munich we have at the moment 4 inhibitors. And we have a total of patients of about 70 patients which were treated like this.
I will now ask Dr. Emna. I know that you started the low-dose prophylaxis since 2007, so we are close to a decade of experience, because prophylaxis has to be sustained. And in order to ensure sustainability, you need to plan the procurement of your clotting factors. So can you tell us your experience? How could you plan your prophylaxis program?
Low-dose prophylaxis, according to me, is the starting point of introducing prophylaxis in countries with limited resources economy. If we did it, it means that it's possible. When we started prophylaxis 10 years ago, it's not the same that we are doing now. We improve step by step. And one of the biggest challenge is how to start prophylaxis when we don't have enough clotting factor concentrate. So in the beginning, when we start to identify the patient who will need prophylaxis, first we chose to start with children, and secondly with children who bleed frequently. And when we calculate the amount of the clotting factor concentrate for some children who bleed frequently and calculate the doses, if we use a low doses prophylaxis, I mean 10 to 15 units per kilo twice a week at least, it's almost the same, if not the same quantity. So this was the starting point of introducing low doses prophylaxis. Then, as a second step, when we show that this experience modifies the quality of life of patients and parents, we said we have to extend the experience to the other children. And as a second escalation, we decided to put all children going to school with a low doses prophylaxis. It's true at this point that the consumption started to grow progressively. And then we decided to start earlier, and that's what we are going, let's say it's 3-4 years. We try to start as earlier as possible. I mean, after the first or second joint bleed, we start once a week, because it is not very easy for the families to have a treatment without bleeding. They cannot accept this easily. Now it's true that we have an experience of 10 years, and we hope that with the results, all the communities of hemophilia in the world will be able to give prophylaxis to children, because we think that in 2016 prophylaxis is the gold standard treatment for children at least. If I have to convince the authority, I think that the main outcome assessment that we can use and that is very easy to demonstrate is the reduction of the annual bleeding rate. Because starting through the annual bleeding rate means less emergency, less absenteeism in school, possibility to achieve university level, to be more productive in the society after, and also less surgery in the future. So we could save money.
Thank you, Doctor. So, Doctor, can you tell us a little bit about the experience in your center?
Prophylaxis is a long story in China. So we're beginning to do the prophylaxis that I think is 2007. At that moment, we in our center we have find a lot of patients who is in school age, around school age, also have atrophy, also disability. That is for severe hemophilia. I think I remember that is 2/3 of them have disabilities. At that moment, we don't have health insurance. We don't have product. So what we will do, we just choose low dose prophylaxis. That means we used 10 units per kilo twice a week. Twice a week for hemophilia A and 20 units per kilo for hemophilia B. We do a prospective cohort study that is supported by Charity of China, of our hospital. The result is excellent to compare to the routine treatment in our center. That is excellent. So decreased more than 80% of the joint bleeding at that moment. That means that is a tertiary prophylaxis, just we use low dose. After this achievement, we do a multi-center in the country. Just 3 centers enter this, but the result is excellent, the same. So with this very good result, so we separate our experience to all the country. At that moment, a lot of patient parents and also the physician, they know, oh, low dose prophylaxis is excellent, it's good. So a lot of patients who is in without any joint bleeding, without any joint situation, they think, oh, maybe I want to try this. I follow the German practice that is we use once a week low dose. That means 20 units per kilo every week. So with the health insurance is better and better in China, the age of our prophylaxis is younger than younger.
I will ask Dr. Günter, what do you think the best age to start prophylaxis? According to the age, what is the best, the frequency of the infusions that you think would be effective? And third, do you think that to start early and insert an indwelling catheter in a developing country is a safe practice, or it is better to delay, let's say, not to start at 1 year, but start at 2 or 3 years when the veins are more clear? What's your recommendation?
So we have also a development in our treatment. When we started 15 years ago, we started mostly after the first year. Sometimes before the first joint bleed, but when the child had a lot of bleeds. And then we started always earlier, because we realized that we have two aspects. The one is the joint protection, but we know that once weekly prophylaxis will not protect the joints. We need more injections per week. But the first joint bleeds occur usually during the first and second year in most of the patients. So our aim was to start as early as possible, because we know that we also have the aspect of inhibitor avoiding. And during the time before the first birthday, we usually have not severe bleeds in these children, except intracranial bleeds. That can also occur. And we now start between 8 and 10 months. We start with the lowest dosage we have in our vials, that is 250 units. For me, it would be more acceptable if we even had lower dosages. And we start once per week. And this has another aspect, what you asked about the indwelling catheters. We can avoid them, because treatment once per week, even in a small baby with not so good veins, you can treat them. Once weekly is possible. And our parents are learning this, injecting in the small children about 1 year, when the children are about 1 year. So they can do it themselves, which is very important in countries where you are far away from your center. Not everybody is living close. Then if they can learn it, they can do it at home. And especially if there is a bleed in between, they can treat the child immediately. They have not to go for maybe hours to the center and wait. And so it's also cheaper, because if you treat immediately, mostly you give 1 shot of factor concentrate and everything is okay. If you wait, and we have a lot of literature for this, if you wait longer, you need 2 or 3 injections, which is also an aspect of economy. So we can avoid the portacates or so. And one aspect of these portacates is also that we know that surgery is triggering immune reactions. So surgery in small children will be a problem.
As we are now, for the other centers, introducing the prophylaxis, which is, of course, an added cost to the health budget, then we need to show to our financing authorities the effectiveness of what we are doing. And this is usually a long term to show this.
So in my country, we have started low-dose prophylaxis. Actually, initially I'd thought it was going to be the lowest of the lowest doses. But from my panel colleagues, it looks like, we are all on the same page, because we are also doing 10 IUs per kg, twice weekly, not once per week. We had initiated a once per week dose, and we didn't really experience much until we felt that the children, the age group we had enrolled, were a bit active. We had children of, between 3 years, 2 years, relatively busy children. Some of the children within that age group were being brought to the hospital very frequently. And so when we started this prophylaxis program, now the children and the parents are more stabilized. They have a schedule, so they can now be able to plan for their children, take their children to school. They can plan themselves in terms of their jobs that they are doing, and so they can contribute to the economy of the country. So one thing that we are trying to use as a marker to assist us so that we can convince the authorities is that, one, first of all, we can allow these children to grow normally and become and aspire to be professionals through education, so they're able to attend their schooling. But at the same time, even for the parents, they can actually now be able to work and contribute to the economy. Because initially the problem was that they are consistently coming to the hospital because of bleeds.
So you mean that, implementing the low-dose prophylaxis could reduce the number of bleeds, and so the patients do not need to come to the hospital frequently?
So basically the patients now, the children first of all can live normal lives. Take it from me, it was such a frustration to the parents before. Because every other time they want to do something, they're bleeding. And they have to keep running to the hospital all the time. But now with prophylaxis, the children can live like any other person.
We have the possibility to do primary prophylaxis with half dose of prophylaxis. And we have been doing that since 2003 in a regular way. So actually we use the once a week regimen. We start with once a week and we escalate to 3 times a week by the year, or between 3 to 4 years old. But now we are introducing the concept of a low dose of prophylaxis in adults and in young adults, just to avoid stopping prophylaxis under the age of 18. And now we are showing the authorities that this schedule of low dose of prophylaxis, maybe 10 to 20 units per kilo twice a week in an 18-year-old or 20-year-old young, is better than to stop prophylaxis and to start an on-demand treatment.